So we left off with the rationale for selection of the materials to make sure that we're placing these materials in the correct spot in the patient's mouth, as well as making sure that it's aesthetic enough and functionally resistant enough to occlusal forces. And as far as veneers, remember that those are those thin layers of aesthetic materials which are used to improve the appearances of the teeth. They are used for cosmetic or aesthetic purposes only. Insurance companies generally will not pay for veneers, so keep that in mind when recommending these to the patients and trying to explain those financial agreements with patients that insurance companies will not reimburse patients for work on their teeth to have a veneer placed. So we'll move on to the next slide, which talks about porcelain failures. So these can start out as small cracks, roughened surfaces, or chipping at the margins. And what we see here in this photograph is a porcelain fused to metal crown that the porcelain has fractured from the facial surface. And we also see this telltale silver gray lining around each of the margins of these teeth. You can also see that the tissue doesn't look particularly healthy there. We also have some restorations on the lower arch as well. So this is showing the oxidized metal, the opaquer that is painted over that metal so that the grayness doesn't show through, and then the level of porcelain that is left after the fracture had occurred. So these porcelain failures typically result from small cracks in the porcelain that develop when the porcelain is put under occlusal loading, so when the patient chews. And then they propagate, become larger and larger over the time until the porcelain finally fractures and gives way. The book is telling you to avoid acid etchants and acidic fluorides on ceramic restorations because they will roughen the surface of the ceramic and help with that propagation of the fractures. The porcelain surface, once it's been fused under a high temperature, is very hard and very smooth. All of the glass-based ceramic material should be bonded to the tooth with a resin cement. When porcelain or porcelain fused to metal restorations are delivered, they often must be adjusted to ensure proper fit. These adjustments do remove the glaze that was placed on them in the lab from the finish. These restorations then may be returned to the laboratory to be reglazed before they are cemented in the patient's mouth. It's important for the clinician to identify the junction of the tooth and the margins of any ceramic restoration because the margins could be chipped with scaling procedures during a hygiene visit. The figure here once again shows that these porcelain failures that can occur when especially they're bonded to the metal. When the metal is exposed, as in the portion of the opaque layer of the porcelain, which is used to prevent the metal from showing through, the rest of the porcelain also fractures away. And one of the really big downsides of having this in the patient's mouth is this is really a non-restorable situation. We can place composite over there and try to bond a composite, but it's really a band-aid for what's happening because once that porcelain has fractured, there's no way to reliably restore that once again. When the clinician is finishing and polishing the ceramic, it's important to use a light touch with that, not use too much force or energy, and use a low-speed handpiece to not create the friction. So following both of these principles will minimize the generation of heat in this, on the surface of the ceramic and the subsurface to prevent damage. When trying to achieve a smooth surface, it's important to follow proper sequence of progressing to fine and yet even finer abrasive materials to polish these. So we're going to start with a coarse and then end with a fine or superfine abrasive to create the most polished and smooth surface of these ceramics. This figure shows a ceramic onlay after it's been polished and cemented. So this tooth, you can see a little bit of a margin here, but otherwise this looks like a very, very beautiful, very functional restoration for this patient. There's a composite here in this tooth in the occlusal, and it looks like a little bit of hemorrhage that had happened around the gum line here, but patient looks like it's healing well. The cementation of all porcelain restorations, of course, the restoration is going to need to be tried in to the patient's mouth before it is cemented to make sure that the margins are nice and in contact, that preparation is not too high and is comfortable for the patient. So we're going to try it in, prepare the restoration for cementation, and then prepare the tooth by also possibly doing an acid etch or just cementing the restoration in the mouth, and then finally the cementation. So remember, the glass-based ceramic internal surface must be etched with hydrofluoric acid for 5 minutes. So usually once that restoration is tried in and is acceptable, the etching and preparation of that porcelain ceramic surface will be readied. After the etching of the internal surface, the surface then must be silanated by another product. Non-glass ceramics do not etch well with hydrofluoric acid, and they can be sandblasted internally to provide the roughened surface that's necessary to cement these. The prepared tooth surface is wiped with a wet cotton pellet to remove any remnants of trying materials, and it's important to remember that isolation is key, and any contamination or bleeding should be controlled before the cementation process is begun. The tooth surface is then conditioned according to the manufacturer's instructions for the bonding agent being used. Conditioned typically means etched. A bonding agent is then applied, and the cement is applied to the internal surface of the prepared crown, and the crown is then seated on the prepared tooth. This would be for the pressed type of ceramics that would need all of those steps. Some of the steps, such as the feldspathic, just needs to be cemented in the mouth. There's not a lot of prep that needs to happen with those types of products. It's based on the product that is prepared for the patient. Lastly, we're going to talk about taking shades. We talked about this a little bit in specialties, but we need to remember that there's a hue, a chroma, and a value that is necessary to take into consideration for your patient to make sure that they get the best end result that they're looking for. Use proper lighting and use a neutral background. Pastel blue patient napkins are also very good kind of backgrounds for choosing the shade. You as a dental assistant may be asked to assist the doctor in choosing that appropriate shade for the restorative procedure. An inappropriate shade will result in a mismatch of the patient's dentition and possibly a remake of the restoration. The characteristics of hue, chroma, and value must be taken into consideration when the shade is determined. The lighting in which the shade is viewed is important. Most offices have a combination of fluorescent and incandescent lighting, but natural light is preferred, and some offices replace their light bulbs with a natural light mimicking sunshine coming from the north. I use that neutral background. Best color of the patient napkin when selecting the shade is that pastel blue. That's why it's one of the most popular colors for doctors to have in their office. Patients should also remove any lipstick or heavy makeup and cover their colorful clothing, and that's another reason why we use that pale blue in most dental offices. And this set of photographs shows how the dental assistant or the clinician would hold up the shade guide and try to match those hues, chromas, and values. When we have this larger palette of shades, we hold that up to kind of get the beginning match, and then we hold the individual tabs up to the tooth. When we're doing something in the very aesthetic areas of the maxillary anterior, I also give the patient a mirror and say, tell me what you think of this. What do you think? And if the patient says, I like it, then we go through and then we chart and document what they like, and the patient is a helpful partner in choosing that shade. So make sure you're incorporating their assistance for that. In summary, a wide variety of tooth-colored aesthetic materials are available to the team for use in restoring a patient's dentition. The dental team must work together when utilizing these materials, and an understanding of the properties involved will contribute to a successful outcome for both the office and for the patients. Because patients do demand high-quality restorations with a close match to their existing teeth and shades. And in some cases, they demand those restorations that produce a lighter, youthful smile. If you have any questions, make sure you contact me, and you can email, text, call, and let me know what I can do to clear up any questions that you may have. Thank you.